I prepared 3 different cases here for all of you, and first of all, I'm just going to put up the case, show you the lesion, and then we can discuss how you would approach, and then I can show you what I did, and then we can discuss if this was a good solution or if I did bad. So this is a very easy lesion in the SFA, stenosis here. Rather for 3 patients, how would you approach that one? I started with the easy one. So who takes the easy question?
Okay.
Sorry. So Gunnar, this looks so logical, you know? You're going to do POBA. I'm sure you're going to proceed with a nice DCB, and you're going to be finished in 10 minutes.
Yeah. Actually, what the point I would like to make here, this kind of like, it's a primary stenosis, not a restenosis, an easy lesion, kind of. But we treated this with a drug-coated balloon. This was the result after the intervention, and then I already showed that this is the follow-up. The follow-up at 6 months was a positive remodeling. And the point I really would like to make here is, and I've heard this in discussion several times, is that the data, most of the data are available for TAS A and B lesions, primary stenosis. And there are some people who say, okay, I just do reserve the drug-eluting balloon for difficult patients, restenosis, instant restenosis, whatever. But I think most of the data are available for those, and those patients are really doing good. This is really the approach which I think I go, and we should go as DCB first. In TAS A and B lesions, I really have a problem redefining a patient where I should not use a DCB, just PTA only.
I mean, you take in consideration only length as an indication, but we have also some other factor to decide which kind of device we can use. For example, we have the clinical presentation of the patient. I think that there is a huge difference between claudicant and CLI patient, for example. Also, like morphological factor, we can take account calcification. Do you perform CT scan before this kind of procedure?
No. And I'm going to present you only patients which are claudicants, no CLI patients right now. And we just do an angiogram very often, or have an ultrasound and just do the intervention. No CT scan.
But coming back to your point that it's difficult to find a patient in the SFA PE region not to use a TCP if it's a claudicant. I think we have data available, and you might show us that we are cost effective at the end if you use a TCP because the patient is not returning. And even if you say, okay, patient selection or whatever, patients with PAD, they are not getting better over the time, so they are getting worse. And I think if we have the advantage not getting these patients back in a certain time frame, I think that should be our goal.
Yeah. Okay.
The cost effectiveness is a very important point, I think.
Yeah.
But if you look at the cost effectiveness analysis just published about impact, they didn't show any difference in terms of ICER, which is a main endpoint regarding the cost effectiveness. So I think we need evidence more to show a difference in cost effectiveness when you use this kind of devices, obviously.
For sure, but this data will only come out in the next future. And what we have at time now, we have randomized controlled trials where we show efficacy. I agree with you that cost effective is a very important point. But anyway, I think we also have data on that point that if a patient with PAD is not coming back to be treated once again, because besides cost effective, we also have to take into consideration how the patient is looking and how the patient is presenting, and PAD patients are usually not the healthiest ones.
Okay, I have to interfere here a little bit because I have also limited time, and if I do discuss in between, I have no control of that anymore.
Okay, sure.
So I try to control this a little bit. Over here, again, my point is here, in the case, short lesions, also DCB. And this can be also seen in this slide over here. Another case, this is a more complicated case. This, of course, I just put this up here, just we already crossed this with a guide wire task D lesion and pre-dilated everything. And this was the result after pre-dilatation. This is the result. How would you proceed? And this, I think, is more interesting. So how would you go with the DCB first, stent first, DES first? How to treat that patient?
Okay, I can go first again. I mean, looking at the pictures and from the very beginning, Gunnar, I think it's very difficult to resist not putting a stent in this case. The indication to begin with, claudication versus CLI, is a very good argument made by Jan, but in such a long, complex lesion, even in a claudicant, from the very beginning, I'm very, very keen to do a long drug-eluting stent, especially in the absence of a lot of calcification.
Yeah, I think that's a good point. So I can tell you what we did actually. This is a patients which we did in a prospective randomized trial, sports trial, where we really compared drug-eluting stents, the Illuvia stent versus drug-eluting balloons versus primary stenting. This patient was randomized to the drug-eluting balloon arm. So what I did actually, this was a 4 millimeter pre-dilatation. We used drug-eluting balloons here. And this was the result after the intervention, right away. So I used the drug-eluting balloon, and the dissection got worse. And then at the end, as you see over here, I had to stent the whole thing. But first of all, drug-eluting first, and then stent. So my point here, also my learning point, my personal learning point, yeah, it might be in that way also a good option to go with drug-eluting stents first. Nevertheless, here we have drug-elution and place stent second. And if we look, and this slide has been presented already, look into the literature, as longer the lesion gets, as more stents we will place, we do have to place. So the question for me is, this is also a good way, but if we have really such a severe dissection as over here, it might be that at that time point we also, besides DCB treatment, we could go right away with the DS.
Can I just quickly ask you, Gunnar, we always get the question, do you do a DCB followed by a BMS, or do you do primary DES in case of a bad dissection?
Because that's my talk, and that's also my way to go. I always try DCB first. So I go DCB first, and in a lot of cases, I don't have to stent, doing a proper PTA. And in other cases, I do have to stent, but to spot stent. And in this case, because it was really severe dissection, I have to stent the whole lesion.
I have a question for everybody. When you perform a vessel prep or DCB treatment, how do you assess the results? In a randomized clinical trial, we perform a different view, perhaps duplex scan. Do you perform a different view or a duplex scan in routine practice to assess the results of a vessel prep or DCB treatment?
We did different angulations and look at from different views. Yeah. So that was the way how we addressed that issue. Michael?
Yeah, I think that the argument Gunnar brought up is also my opinion. To start first with the DCB, you then have the chance to end up with shorter stent situation than you go if you would go directly with a drug-eluting stent, which would mean in that case too that you end up with 150, 170 millimeter of full metal jacket implantation. With that approach, you have the chance maybe go only out of that case with 2-3 spot stents. I think, and this is the approach I would also prefer.
I think we have to learn much more, and in order to present the last case, I would like to go on. And this is an instant restenosis. This patient was treated with a primary stent placement, and this was a PTA result, and we thought, okay, we should stent that, residual stenosis, calcium, and so on. And this happened at 6 months. So what we did at that time, and this is in order to be a little bit faster here, we did a PTA only. And this was quite some years back, so I think it was in 2011. We did a PTA back, and as you might imagine, this is after the intervention. The patient came back with an instant restenosis. So what would you do here? Instant restenosis? Another indication for DCB possible?
DCP.
So we did a DCB. And in this patient, I do have a follow-up, and I have a DCB treated with a DCB. And this patient came back, unfortunately, 5 years later. So this is after the intervention, so after 5 years we had that one. So my personal learning here is, compared to POBA, yes, it works fine, but at least there might be the chance, and there are also the debate data up to now, that even with a DCB you get a restenosis, an instant restenosis, if you treat this with DCB. I did this here. Of course, 5 years later, it's much different compared to half a year. Instant restenosis is a bad animal.
I think, Gunnar, that's a great case. And what I would like to also point out looking at this picture is, looking at the top of the blocked stent, you can see more disease there. Now, what we really don't know when we are discussing long-term results is what is the background disease? What is the natural history of the disease? So is it really the DCB that has failed, or is it new disease?
Yeah, good question. So nevertheless, how would you treat that patient right now? DCB again?
Yes, but maybe with debulking before.
Correct, I would agree
So
with the bulking strategy.
I did it my way, in a different way. So actually, this patient was randomized in another registry. I placed a covered stent graft in this patient because it was a total occlusion. Of course, you could also debulk, you could also use DCB. Nevertheless, I do not know what's the best way. So these things have to be discussed, and I think there are data, especially for instant restenosis, that DCBs do work and reduce restenosis rate, but anyhow you can also have a re-restenosis after DCB. So that are my cases. So anything else?
Great cases.
Okay, thank you.